Thank you, dear Chairman and dear colleagues. I'm Dr. Hasan Yilmaz from Kocaeli University School of Medicine and Kocaeli University Gastroenterology and Hepatology Institute. Today I'm going to share my information about the debatable indication for the achalasia. In this photograph you're seeing the Turkish gastroenterology, women gastroenterologist working group. Actually we have a dedicated working group just for the women. We cannot go into their rooms. They're just full of the women, and it's my honor to bring their greetings to you. These will be the topics I will cover in the rest of my presentation. As you all know, achalasia is a motor disorder of the esophagus characterized by peristaltis and impaired relaxation of the lower esophageal sphincter, which leads to chronic dysphagia and regurgitation and chest pain. And before poem, the main treatment options available for the achalasia were medications, botulinum toxin injections, and primitive balloon dilations, and laparoscopic helermyotomy. The selection of the therapies for the achalasia has remained the topic of the debate in clinical practice. For many years, the selection of the treatment strategy was based on the primarily experience of the operations and the willingness of the patient. However, patient response to various therapies differ, and in these days, HRM, the high resolution manometry, and the Chicago classification reveals us to choose the patient. Achalasia type 1. Basically, abnormal median IRP and 100% failed peristaltis is going to be the achalasia type 1. Type 2, abnormal median IRP, 100% failed peristaltis, and greater than 20% of the swallows will be the pan-esophageal peristalsis. Achalasia type 3, abnormal IRP, and no evidence of peristaltism, and greater than 20% of the swallows will be the premature and spastic contraction. According to these subtypes of the achalasia, phenotype-directed treatment. For what does the poem stand? To answer these questions, I will present you to data from the different studies. Firstly, Kim and colleagues examined the response of the patients to poem treatment according to the manometric achalasia subtypes. They found ECOG score treatment basis 97% of the patient for the type 1 successfully give response, and 100% for the type 2, 90% for the type 3. When pre and post-treatment ECOG scores were compared, statistically significant improvement was achieved in all types of achalasia. The meta-analysis published in 2023, Zhang and colleagues analyzed a total of 747 patients from 8 different studies who undergone PIAM. They found the clinical success rate for the type 1 achalasia as 86%, for type 2, 87%, for the type 3, 83% of clinical success. These results suggest that POEM is effective in all types of achalasia. And the last one. Recent meta-analysis compared the clinical success of the different treatment modalities in achalasia phenotypes. They analyzed over 1,000 patients, including 25 studies. Treatment success for POEM was over 90 for all types of achalasia. When it comes to the laparoscopic helermyotomy, the best result was seen at type 2 with a success rate of 92%. Primitive balloon dilation was effective for the type 2, but when it comes to the success at the type 1 and type 3, the success rate declines. As you can guess, botulinum toxin injection has the lowest clinical success rate. As a result, POEM is indicated in all achalasia phenotypes, and it's a very good comparable clinical success to helermyotomy PD and botulinum toxin injection. As we all know, manometric criteria to diagnose achalasia are absent peristaltis and incomplete relaxation of the EGJ, determined by an integrated relaxation pressure of the IRP is going to greater than 15 millimeters. However, EGJ relaxation seems normal in a subgroup of patients typical achalasia symptoms. No endoscopic abnormalities, studies on the time baryography, and absent peristaltitis on high-resolution manometry. Pons and colleagues aim to further characterize these patients by measuring EGJ distensibility. These are the example of the endofluid measurement during all distension volumes in the healthy subjects and the patient's baseline. Values in the right panel, the diameter of the bag, and the bottom is going to be the pressure of the balloon. Healthy subjects had a significantly high EGJ dispensability compared to the patients. Treatment significantly improved the EGJ dispensability after treatment. Further, Kim and colleagues analyzed the clinical success of this unique subset of patients with the absent contractility and normal IRP. As you see, 28% of the patients had normal IRP out of 89 patients. Normal IRP patients were turned to older, longer duration of symptoms, more tortuous esophagus, and distensibility index were higher. Therapeutic outcomes, it's very important to hear, therapeutic outcomes showed no difference between these two, normal IRP and elevated IRP group. Correlation analysis finally revealed IRP had negative correlation with the age, disease duration, and distensibility index. Another controversial indication for the POEM is neglected or sigmoid achalasia. Initial reports revealed POEM for advanced disease and sigmoid achalasia can benefit from POEM. Huwei and colleagues were prospectively included 32 consecutive patients with sigmoid achalasia. Mean follow-up of 40 months, treatment success was achieved in 96% of the cases. Pre- and post-treatment ECART score and less pressure significantly improved. Most frequent adverse event was mucosal injury. Sigmoid achalasia, a patient who underwent the POEM at 12 tertiary care centers between 2019 and 2015 were included in the case contrasted by the Chavez. And they found sigmoid type achalasia is the most important and significantly independent factor for the adverse events. If someone intends to perform an POEM for the sigmoid achalasia, it's very important to be skilled endoscopist because of the technical difficulty due to the complex anatomical features of the esophagus. Another rare scenario is the association of the achalasia and epiphrenic diverticulum. Both entities can cause dysphagia. In this case, diverticulum resection, myotomy, and the fundoplication were performed in the pre-POEM area, but complications related to procedure were common. So authors questioned necessity of the resection of the diverticulum. Allo and colleagues found no difference in clinical success between myotomy with epiphrenic diverticulum and without epiphrenic diverticulum. Later on, 2020, Kinoshita showed there is also no difference in terms of ECART score performing a myotomy alone instead of adding it a diverticulotomy on the POEM. And achalasia with hiatal hernia. Achalasia with hiatal hernia, a rare association. HRM revealed a type 2 achalasia hiatal hernia. Please note the position of the lower esophageal sphincter above the diaphragmatic impression. They treat the patient either POEM or PD. Clinical success rates were similar for achalasia with the hernia and without hernia. But as you see, the number of the patients is very low and we need much more data on this topic. When it comes to the management on the failed therapy, in the short term, PD, LHM, and POEM have certain success rates. We all know this. But Kaplan-Meier curves for PD and LHM reveal how treatment success rates for PD, LHM decline over the time. Retreatment could be needed as high as 18 to 27 patients at a median follow-up of 5 years. What about the POEM? There is data about the POEM, and in these days we are going to face up much more relapsed POEMs and at the follow-up at 5 years. POEM after PD is feasible and safe after the failed PD, and success rates are almost over 92%, and there is no big issues when it comes to the adverse events. Another study compared efficacy of the POEM after PD to POEM for treatment-naive patients reported that efficacy adverse events frequency were similar in both groups, so POEM might be a good indication for those failed after pneumatic balloon dilation PD. When it comes to the POEM after POEM, no one is perfect, as you know, although parallel endoscopic myotomy is credited with high success rate in the treatment of achalasia. Persistent and recurrent symptoms may occasionally develop afterwards. Lin Lee and colleagues retrospectively analyzed 15 patients which relapsed and they found therapeutic success was 100%. But again, we need more data. And most of the adverse event is the mucosal injury. POEM offers the advantage of the second myotomy in the opposite orientation of the first myotomy, theoretically decreasing procedural complexity from previous scarring and improving efficacy by decreasing circumferential muscle disruption. A multi-center international study again showed the feasibility of the POEM after POEM. In this study, technical success was 100% and clinical success was 85%, and adverse events was quite acceptable. POEM after laparoscopic hilar myotomy. The best management for the patient relapse after laparoscopic hilar myotomy remains controversial. Pneumatic balloon dilation is often a salvage therapy and it's limited because it needs repeated dilation. Tyberg and colleagues published international data and POEM after LHM has excellent clinical and technical short-term results. Also, there is single-center studies from Zhang and multi-center study from Haruhiro Inoue from himself, and significant level. There is significant technical successfulness in these studies. When you are performing a POEM after laparoscopic hilar myotomy, you should be aware that laparoscopic hilar side is going to be anterior side. And when they are making this, they're going to make some fundoplication sutures at the 2 oculoc side and the 10 oculoc side. And it's wise thing to be stay at the posterior, ideally at the posterior wall between 4 and 6 o'clock. And when it comes to elderly patients with achalasia, have a high risk of aspiration pneumonia due to the reflux caused by achalasia. Therefore, treating achalasia in elderly patients is crucial to prevent pneumonia and improve quality of life. In a study compared POEM and PD treatment results in patients over 65 years old, age treatment success was similar and no serious complications were encountered. Another one compared POEM outcomes in patients over 65 years age with those in younger patients, and they found a great clinical success. Please note that ASA classification consisted of mainly 1 and 2 class. Clinicians who intend to carry out POEM on patients in these age group should carefully evaluate the patient's tolerance and endoscopic procedures and anesthesia status. And lastly, we are as long as we are dealing with the older population, we will face up more patients on antithrombotics. As you can see, despite stopping antithrombotic drugs for a sufficient period of time, bleeding is still most common adverse. In this patient group, it's vital that the endoscope is prepared for and willing to accept serious bleeding. And I guess it's on time. I have to rush a little bit, I'm sorry, but I have to cover many things. Thank you for your patience.
Thank you very much, Dr. Hasan Yilmaz. Now we have only time for 2 questions, so I would like our advisors and our commenters, if you have any questions.
Can I make a comment?
Yes.
Good afternoon to everybody. I'm Dr. Roberta Maselli from Italy. I'm sorry to be not there with you only online, but it was my pleasure really to listen to this great comprehensive review of all the, let's say, advancement that we've done in these years with POEM for achalasia. And it was a great lecture, and it seems that nowadays we can offer POEM for every type of achalasia, even if it is a failure of different treatment done before. It's a provocative question. Do you think that there's still any place for laparoscopic Heller, and do we have some subgroup of patients where maybe it's better to perform the Heller myotomy instead of endoscopic myotomy? What do you think?
Well, it's not easy to operate people experience laparoscopic Heller myotomy. Remyotomy with the laparoscopy is not going to be easy because of the severe fibrosis. But if you can go with the POEM, it's going to be much more easier because you can easily navigate from the non-fibrotic side when you are at the lumen. Okay, I guess it's going to be much more easier to perform POEM instead of remyotomy with the LHM.
Okay, thank you, Roberta, and we welcome you online. Thank you for participating with us. Thank you. Professor Dr. Amrita?
Yeah, wonderful lecture. Just wondering how you modify your poem techniques for these very difficult, particularly the sigmoid or the post-Heller, where some of your original landmarks that we learn very classic techniques for are not always available, or you're dealing with a lot of scar and fibrosis.
Yes. You know, it's very important to see, try to maintain, not to get lost in the tunnel. You know, when it comes to the very kinked and L-shaped, and maybe sometimes 2L-shaped segmental achalasia. And it's significantly, you have to be aware about how the muscle layer is going through the tunnel. And my advice is very frequently go back from the tunnel and see where you are going and go back again in the tunnel. It's very important because you can easily lost at the sigmoid achalasia. It's not very easy and it's very technically demanding. Before starting a sigmoid type achalasia poem, you should master at the regular straight types. It's very important, I guess.
Okay, thank you. Dr. Magdi?
Quick question to Dr. Shema. How much do you rely on cross-sectional imaging or EUS before planning your procedure?
Thank you for the very nice question. Actually, all the papers had proved that optical diagnosis, optical endoscopic diagnosis is number one. It's number one. Sometimes we can use the EUS or MRI and the rectal cancer as long as we're speaking about superficial rectal cancers or superficial GI cancers. Optical diagnosis is number one. EUS cannot reach all the places. It can reach the upper GI or even the rectum, hardly the sigmoid, but they cannot reach the whole colon. So we depend mainly on, for the first degree cancer, we depend only on the optical diagnosis. If we need to do, if we are suspecting more than T2 or more, we can do EUS, we can do MRI. But actually, if it's all the studies, and even from our practice, optical diagnosis number one. You can find sometimes EUS, MRI doing like an over-diagnosis for cancer, but when you see the cancer by your own eyes with the optical enhancement and all the criteria that we use, you can find it that it could be endoscopically resected.
Can I have a question of Dr. Sherbini? Do you prefer not to biopsy the lateral spreading tumors you showed us before doing ESC?
Yes, before. Yes.
No biopsy.
Yes,
Absolutely.
sure. No
Absolutely.
biopsy. That, as we mentioned, and Shaima just finishing her speech about the optical diagnosis, very important. You have to examine or inspect the lesion thoroughly using the all optical enhancement with the scope, high definition, chromoendoscopy, digital chromoendoscopy, even magnification endoscopy. If you see that this lesion is resectable, so don't take biopsy. Just only if you see that you see some areas of suspicious of deep submucosal invasion in a location right as if it's a right colon, and it's difficult to make CT or MRI or even EUS. So if you see the lesion and inspect the lesion thoroughly, you have to take the decision, just depend on the optical diagnosis. And we don't recommend for the biopsy because it will go for deep or submucosal, some sort of fibrosis. Even if don't do or don't go for a submucosal lifting, some of endoscopists going with submucosal lifting, it's lifting, then he stop the procedure and send it to me. So even submucosal injection, you have to inject if you start or you're ready to resect the lesion.
Dr. Sherbini, please, what about the incidence of perforation and its management?
The incidence of perforation.
After ECD, I mean.
Yeah, it's according the location mainly, and according the procedure and the lesion of the submucosal fibrosis. So if you are working or dissecting or resecting the lesion in the right colon, it's a very thin colon, so the perforation rate will increase. But even if you didn't perforate the wall, you have to close the cecal or right side colon. If you are working in the stomach, like in the antrum, it's a very thick wall, so the rate of perforation will be very low. So it's depend on the location, it depends on the previous trial or even the submucosal invasion, or sometimes you can see if the lesion is infiltrating some sort of the deep submucosa, so you have to go to the deep submucosa, and this will carry high risk of the perforation.
Thank you very much. Dr. Hatem, last question, please. Yeah?
Excuse me. If you have a thorough endoscopic evaluation of the lesion 2 centimeter size and there is submucosal invasion, which is better to cut through submucosa, through EMR or ECD?
If you see any suspicion of submucosal invasion, so it's better to go for the ESD if you see submucosal invasion. And also it's according to the location. In last 2 slides, that's Shaima show you that now we have some expanded criteria. It's not yet proven for the distal rectal lesion. Even you can see a suspicious lesion of T2 anal lesion, you can go for even intermuscular dissection. So if you are seeing the suspicious of deep submucosal invasion, I think EMR will not help you in this situation.
Thank you.
By this, we come to the end of our great session. Thank you, dear speakers. Thank you.